Hello everyone, a very warm welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. I would like to begin by acknowledging the Ngunnawal and Ngambri people who are the traditional owners of the land where ANU is located and where we are broadcasting to you today from, and I pay my respects to their elders past and present. We are pleased to welcome attendees from various parts of Australia and the globe, including India, Indonesia, Burma, Fiji, China and South Africa. Knowledge is power, and our weekly webinar series allow us to share and learn from each other's experience during this pandemic. Today, we are delighted to have with us a speaker from India, where doctors have managed a large number of patients during the Delta wave. I am Devashi, a medical student and volunteer for the ANU COVID-19 peer support program, and joining me are my colleagues Evangeline Wong, another medical student and volunteer with this program, Dr. Pinky Dharmshaktu, who is an associate medical director at Merck Healthcare and also a volunteer with this program, and finally Dr. Deepthi Talawalekar, who is a hematologist and program lead for the ANU COVID-19 peer support program. Now, begin I introduce our speakers and panelists for today. A couple of housekeeping notes. All attendees have their video and microphones switched off, and this is just to keep the sound quality clear and reduce any interference during the webinar. I encourage all the attendees to ask questions, and to do so, please use the Q&A button, which you can see towards the bottom of your Zoom screen. If you do not wish to be identified, you can submit your questions anonymously, and you can submit your questions at any time during the webinar. The panelists and the speaker will get to your questions towards the end of the talk. There will be some questions that might pop up on your screen, especially a rating poll, which will help us gain some feedback from you. Please do select your preferred response to those questions, and we can assure you that all responses will be anonymous. If you have any technical issues or questions, you can email us at international.health@anu.edu.au, and we will try to assist you as best as we can. And finally, please note that this forum is being recorded. So today's webinar will be delivered by Dr. Satish Ghanta on pediatric COVID and multisystem hyperinflammatory syndrome, MISC, in children. Here, he will be sharing his clinical management experience in the pediatric population with MISC during the first and second wave in Hyderabad, India, through a case-based presentation. This will be followed by a panel discussion with our panelists, whom I will shortly introduce, and they will discuss more practical issues from their clinical experience and also answer any questions from the audience. Dr. Satish is currently a development pediatrician, neonatologist, pediatric intensivist, and the director at Little Stars Children's Hospital in Hyderabad, India. He completed his pediatrics training from KMC Manipal and has spent time in the Sydney Children's Hospital as a pediatric intensive care fellow as well. Next, I would like to introduce our esteemed panelists, Dr. Sujit Thumala, who is a pediatric intensivist at Little Stars Hospital, and Dr. Sridevi Nayani, who is also another pediatric intensivist at Children's Stars Hospital. And it is our great pleasure to have you all here. Now, with this, we will begin the webinar itself.
Good evening, everybody at Australia. Namaskar. It's certainly a privilege and an honor to be here right in front of you, trying to share our thoughts, share our views as to what we've been going through in the last sort of 15 to 18 months, and what you could experience in the coming months as Sydney, Canberra, and pretty much the whole of Australia goes into lockdown. So it's always nice to share knowledge and spread it around, because when we had the first wave in the year 2020, that was in May, we absolutely didn't know much at all. And the first kind of cases that we've managed with a lot of difficulty, we did have a lot of difficulty. So obviously our colleagues from abroad who had managed similar kinds of cases in Europe, they've helped us out in trying to say, how do we go about managing these children. So it was certainly a learning experience for us. And 16, 15 months on, now we've seen a lot of children where we've evolved with time as to how we could manage these children best. So it's certainly a journey for us. And I hope whatever endeavor that me and my team we're trying to put forward over the next hour, if it helps you to understand the kind of management struggles that we went through, and that would be a lesson well learned for all of us. And it's a beautiful thing, like when Devashi mentioned in the beginning, that's where the university is situated. I mean, it's a beautiful thing where we share knowledge in a similar way, not only in Australia, but across the world as well. So in this next 40 minutes, what we're going to do is we're going to do it in sort of 3 phases. First, I'm going to introduce you to the broad spectrum or the classification of pediatric COVID and MISC, that is the multisystem hyperinflammatory syndrome in children. So that takes about 2 to 3 minutes. And the next thing is we'll try to explain our own clinical experience during the first wave that was in 2020 and in 21 as well. So we'll divide that into 2 parts, into acute COVID infections. That's going to be dealt by Dr. Sujit. He's a very good accomplished pediatric intensivist. He finished his pediatric intensive care fellowship at Great Ormond Street, London, and he's done his fellowship here in India as well. So he's going to deal with the acute COVID kind of presentations and its complications, followed by which the MISC, that's the other complication which you see in the COVID children, that's going to be dealt with Dr. Sridevi, who's young and dynamic, and she's a very accomplished pediatric intensivist herself. So once these 2 things are done, then I would like to run you through we've seen hundreds of children over the last sort of 16 months. I'll run you through with 3 interesting cases about how there were challenges and they could be easily managed, and what is the kind of challenge we had in 20 and then how we overcame that. I think that would be interesting. Yes, so first I'd like to go through the spectrum of the disease. So we have the COVID spectrum. On one end, we have the acute COVID infection with mild to moderate kind of infections. And on the other side, we have the moderate to severe or the critical COVID cases. Okay. For the purpose of numbers, we did not include the numbers where we've had so many mild cases where we tried to manage them at home. I didn't include them here. So all the children who needed admission only were included here. So in the moderate, we've had about 16 children, and moderate to critical or severe, we've had about 5 of them. That's about 21 children in that group. Then, as I said, in the acute group, we've had 40 who need admission. Now you come to the middle. Here, this is the actual one I was talking about. That's the multisystem hyperinflammatory syndrome, where initially we did have a struggle trying to sort of get our heads around how to manage these children. This is actually classified into 3 categories. First, we need to any child who's had the infection 2 to 6 weeks later on with red flag signs of high-grade fever, vomiting, pain abdomen, and rash, and multitude of other symptoms which we'll go through shortly. This is actually divided into 3 different groups. One is the Kawasaki group, the febrile inflammatory status group, and the toxic shock syndrome group. So we've managed more than 10 children in the Kawasaki group, or 20 children in the febrile inflammatory state, and the toxic shock syndrome, there were about 11. In that, again, Kawasaki could be divided into children with shock and without shock. And when you go into the toxic shock syndrome, that could be divided again into 3 different groups. That's one with the vasopagic shock, the LV dysfunction, and the children who are resistant to IV immunoglobulins or steroids. And those are the kids who are extremely sick, who need anakinra or tocilizumab and other kind of drugs. So this is our own observational study. As I've said, we've seen lots of children, but we try to limit only to the children who've been admitted. And this is an observational study was done along with the data collection of admitted acute COVID and MIS-C children during the years of 20 and 21. The inclusion criteria is any child above 1 month to 21 years of age, and all children with comorbidities were also admitted and treated accordingly. So I request Sujit to take over the discussion from here and talk about acute COVID and its statistics.
Thank you, sir. Good evening, everyone, and thank you for the opportunity. And for the next 10 minutes, we'll be discussing about our center's experience with COVID-19 over the last year and a half. So we'll be starting with demographics, then we'll go into categorization of COVID into based on the levels of severity, and then we'll have some discussion about what were the outcomes and what was the treatment that we had given. So to start with the demographics, the age distribution. So we had seen pediatric COVID cases presenting across all age groups, and there was no particular one age group which flagged out saying that it was more common in a certain age group. We did see a little more in numbers in the age group of 5 to 12 years in 2020 and 1 to 5 years in 2021, but that is just a marginal change in figures, and that didn't carry much of a significance. So coming to the gender distribution again, there was no difference in the gender presentation because both almost equal numbers of boys and girls did get affected, and the severities and everything else as well were the same, whether it was boys who were presented with acute COVID or girls who were presented with acute COVID. So this is the categorization of COVID that we had followed. So this with all the data that was still coming in 2020 was not very clear, and as data got, as we got more robust data, more evidence, and there were more guidelines, so we had finally come to this categorization of COVID, which is in line with our national guidelines. So we had categorized them into mild, moderate, and severe cases, and these are the inpatient numbers, and we have not included outpatient numbers as already Dr. Satish previously mentioned. So we had seen predominantly moderate and severe cases were presented to our unit, and mild cases we had to admit in some situations, particularly because there were children with comorbidities who needed close monitoring, and there were a few children who came from far off places who didn't have ready access to healthcare. So that is the reason there is a small representation of the mild cases as well in the inpatients, but predominantly it was moderate and severe cases that we had seen. So this is how we have categorized the cases into mild, moderate, and severe cases. In the mild cases, the presentation is predominantly like an upper respiratory infection, like any other flu like illness with fever, sore throat, some rhinorrhea, but there are no respiratory signs such as fast breathing, that is tachypnea, or no signs of severe disease. Severe disease indicating that the drop in saturations is quite profound, and the child presented in ARDS or presented in shock. So we had included critical presentations such as ARDS and shock as well into the severe disease, and making it into 3 classes, that is the mild, moderate, and severe cases. So this is what the WHO has given, but we had stuck with our national guidelines for classification. So coming to the varied presentations of COVID, it is well known now that COVID-19 is not an isolated respiratory infection. It is a multisystem disease, and it can affect any organ system. And speaking of pediatric COVID, the children who have been admitted across, the statistics say that the most common symptoms are fever, nausea or vomiting, and respiratory symptoms such as cough, cold, or respiratory distress. That is what we had seen in our unit as well. We have seen there was a difference in the presentation in 2020 and 2021. In 2020, we had more children who came in with gastrointestinal symptoms such as nausea, vomitings, or loose stools. Whereas in 2021, we have seen it presenting more like a respiratory illness with cough and cold and some amount of respiratory distress. That was the difference, and we don't know why this difference has actually occurred, but these are the figures that we had seen. So we had seen a few children who fall into the critical category, that is the severe, who had presented in shock. So coming to lab parameters, as we have previously discussed, COVID-19 is more of a multisystem disease. It's a diffuse systemic process, and it has a complex interaction between various cascades, such as the immunological cascade, the inflammatory cascade, and the coagulation cascade as well. So there has been a lot of effort and a lot of studies that have been carried out on identifying biomarkers and see if these biomarkers help us in gauging the severity of the illness or they help us in guiding therapy. So these are the biomarkers that we had studied. The biomarkers that we had done are C-reactive protein, interleukin 6, ferritin, fibrinogen, procalcitonin, D-dimer, and LDH. Most of these inflammatory, whereas in mild COVID, it again there's a lot of variation on how these inflammatory markers behave. But having said that, they actually haven't given very valuable inputs in guiding our therapy. They did help us to gauge the severity of illness to an extent, but were not of much use in terms of management of the disease. So we had fibrinogen and procalcitonin, which were a little different in 2020 and 2021, but that's all it is. So coming to the treatment aspect, we have divided it into 2 things. One is the respiratory support that we have given that the children needed, and the other is the drugs that we have used in the treatment of COVID. Though we have I've said earlier that COVID is not an isolated respiratory disease, but most of the children who present to the hospital, who are admitted as an inpatient in the hospital, are admitted mostly in need of respiratory support. So as we all know, the respiratory support can range anywhere from low flow oxygen to high flow oxygen to non-invasive ventilation or invasive ventilation in the children that we have seen prominently, and there are about 10 to 15% of children who are needed invasive ventilation. So coming to the drug treatment that we have used in acute COVID. So in the early days, that was in 2020, when it was not very clear as to the line of therapy. There were no clear guidelines, and there was not very much of evidence that was available. So you can see that we were quite aggressive in 2020 with the use of antivirals and biologicals such as tocilizumab, and even the steroids that we have used various combination of different types of steroids like methylprednisolone, dexamethasone, or prednisolone. Now after more evidence has come, now we are more clear on the line of therapy, and we have very rarely used antivirals or biologicals in 2021. Coming to the steroids, the steroids are the only drugs that have been shown to have some survival benefit, and we did use them in 2020 and 2021. The difference being that with more evidence coming in favor of dexamethasone, most of our inpatients received dexamethasone towards 2021. So this is the median duration of hospital stay that we have had, and the median duration is 5 days that we had observed, and it was not different between 2020 and 2021. In both the waves, the median duration was 5 days. So this is the outcomes of children admitted in our center with COVID. So in 2020, we had 3 children who had succumbed to COVID, and in 2021, we had 1 child who had succumbed to the illness. To mention all the bad outcomes of modalities that we have had, which had led to the severity of this. What we had observed is that children who are growing well, previously fit and well children, seem to fare well in the disease, and we didn't see any mortalities in that group. But in children who have had comorbidities, we did experience these bad outcomes that we would have wanted to avoid. So that finishes my presentation of COVID and its statistics with our center's experience. And next, Sridevi will be taking Missy, will be presenting the statistics about Missy and the treatment and outcomes. Thank you, one and all, for the opportunity.
Thank you, Sujit. Good evening, one and all. I will be presenting our unit statistics in 2020 and 2021. According to the WHO definition, we have divided the missing cases into like fever, who presented with fever for more than 3 days duration, followed by 2 organ multi-organ involvement, more than 2 organs involved, with elevated markers like CRP, ESR, procalcitonin, ferritin, D-dimers, followed by ruling out other infections, and followed by any contact with COVID. Coming to the statistics, demographics, mostly missing will be involving more than 5 years of age group. Unlike KD, like Kawasaki disease, it will be involving in less than 5 years. In our centers, what we have noticed is in the last year, we had majority of the group falling in 5 to 12 years, followed by in this year, we have seen more predominant age group was 1 to 5 years. In both the years, we have seen that females were more infected compared to males. We have categorized missing into 3 categories, where we have first category, we had febrile inflammatory state, followed by Kawasaki-like illness, with shock and without shock, followed by toxic shock syndrome. In the both years, we have seen febrile inflammatory state was a predominant factor, followed by which constituted 48%, followed by toxic shock syndrome, which constituted 26%, which is similar to other studies which was done by Singh et al. These are the common clinical manifestations which the child had presented. Fever was presented in almost all children, followed by dermatological manifestations, which has constituted almost 30%. And loose GI symptoms was seen in most of the 20% of the cases. These are the common markers which we have seen, which are elevated in past 2 years, and these are the common investigations which we have done. And IL-6 was a predominant marker which was statistically significant, but there is no common specific markers which are elevated both in MESI or any inflammatory process or any other acute infection. These markers can be elevated in acute infection, such as in India where tropical infections are more. So these markers can be in tropical infections and can be elevated in MESI. What we have found is IL-6, ESR, and CRP were the predominant markers which we have noticed that they are more elevated in MESI. And 2D echo, we have seen like 6 children who are presented with coronary dilation with Z-score more than interesting, and these are the challenging patients for us. And this year we have seen a dual pathology in them. We have seen actually categorization of MESI should be done ruling out acute infection. But in these children, after treating the proper initial also, the inflammatory markers were elevated and child was clinically symptomatic, who required immunomodulation therapy. So after giving the immunomodulation therapy, the children were improving. In this case, early suspicion, recognition, and early immunomodulation therapy were life-saving in these patients. So we are still in a learning curve. So evidence is lacking in this way, where there is coexistence between co-infection and MESI is lacking. Still, evidence is evolving. In this year, 30% of the children having dual pathology, which we have noticed. In the past year, 30% of the children were having this dual pathology associated with tropical infection. These are the common co-infections which we have seen with MESI this year. Most common being typhoid entry fever, then followed by leptospira, rickettsial, and Acinetobacter infection. Even in spite of treating this co-infection also, the child was symptomatic and requiring immunomodulation therapy. This is the research. This is one of the research area where we need to see whether MESI with co-infection. We need to have the studies so that to prove even MESI can be associated with the co-infection. This is important. This is important in countries like India where tropical infections are more. Coming to the treatment part, majority of the patients have been treated with the non-invasive ventilation requiring HFNC and low flow oxygen support. In 12% of the cases required invasive ventilation, and 1 child required renal replacement therapy. Initially in 2020, the evidence was lacking because the first case was reported in April, where they have initially stated that first line could be steroids or IV immunoglobulin, or next comes the biologics. But current evidence says that both combination of IV immunoglobulin and steroid is better compared to monotherapy. And in steroids, the patients who are presented with KD-like shock and toxic shock syndrome required the high dose of steroid therapy, that is 10 to 30 mg per kg per day. Followed by, in this year, we have given the combination therapy who responded very well. Few cases, like 9% of the cases, are refractory to our primary treatment, so they have required the second dose of IV immunoglobulin, followed by biologics like tocilizumab. The median average length of stay was 7 and 7.5 days during this year and last year, and interquartile range between 4 to 11 days. In the last year, we have one death where the child presented with severe cardiogenic shock with LV dysfunction, with ejection fraction being 20%. And this year we have 100% survival rate, and all have been discharged and followed up regularly. These are the statistics regarding the MESI. Now I want to take over Dr. Satish. Over to you, Dr. Satish.
So what I'm going to do in the next sort of 10 to 15 minutes is I'm going to recount the experiences that we've had with about 3 children that we've managed in the last 15 to 16 months. So let's talk about this child on the pic right now. This is 11-year-old girl, Samyukta. She's admitted she was admitted in another hospital and was brought to the ER on the 12th of August of last year with complaints of fever of 4 days, loose stools and vomiting for 2 days, restlessness, palpitations, and shortness of breath for a day. The admission clinical features and vitals. When you see this child was quite restless, tachypneic and tachycardic with a heart rate of 164 and the blood pressure is around 160, certainly less for a child of this age. Saturations were 93% and the capital refill time was about 5 seconds and more. So obviously this child was in shock. Fluid bolus was given and an inotrope was started right away in the emergency room. And initially the child was on an oxygen non-rebreathing mask, as you see. And if you see the hands and the legs, and if you see the eyes as well, there is a typical Kawasaki kind of a rash. So this RD was persisting. So we had to start this child on heated, humidified, high flow nasal cannula. And that was about 15 liters a minute at 100% FiO2. So with that, she seemed comfortable because the main respiratory support all over the world, people seem to be recommending in all the literature is non-invasive support. And we were very happy that we were able to manage her with just non-invasive support. We've had a 2D echo done. There was a coronary dilatation. The ejection fraction was about 55%. So, and the cardiologist was quite detailed in his examination, and he said, yes, there is an element of myocarditis. And when we took the history, this child had a history of flu-like symptoms in the past, a month ago, and she tested negative for COVID on the 10th of July. But she seemed to have all the symptoms. And then when we went and sat with the family and the mother, then what she's revealed is, unfortunately, this child's father actually tested positive for COVID on the 27th of July, and unfortunately expired on the 30th of July within 3 days. So we quickly had the antibodies done. She was positive for them and elevated inflammatory markers. And as I said, the vitals quite tachycardic, tachypnea, hypotensive, saturation of 93%, and prolonged perfusion as well. So obviously here, one of the important factor here was the positive history in the family, in fact, a death in the family. And that happened almost 4 to 6 weeks prior to the illness commenced with this girl. It's the usual kind of management of shock and the cardiovascular system with fluids. This child needed 2 inotropes, noradrenaline and dopamine. And the management of the MISI, as was previously mentioned, straightforward IV immunoglobulins, 2 grams per kilo. Over a span of 2 days, IV methylprednisolone at a pulse dose, we've given this child 10 milligrams per kilo along with aspirin and low molecular weight heparin. But the fevers were persistent, the spikes were persistent, and the shock wasn't improving. She needed not 2, but by the 3rd day, she needed 1 inotrope, but that wasn't going away. Anytime we tried to wean, the child continued to have hypotension. So that's when we decided, yes, this child, it isn't working. So we labeled it as a drug-resistant MISI, and we repeated the COVID markers. Next slide, please. And they were all elevated. All the COVID markers were elevated. Then we had the cardiologist again. This was last year when we were a bit unsure about how to go about these kind of, because at that time, MISI was itself new. And here you're having a child who's not responding to immunoglobulins. So that's when we thought there were a couple of experiences across the country, and we all had a huddle and say, listen, what do you do with these kind of children? Yes, let's try another 1 gram per kilo of IV immunoglobulin, and then follow it up with tocilizumab or some other biological. Unfortunately, a lot of children, a lot of adults also needed tocilizumab at the same time. It was very difficult to get in the market, so we had to go for itolizumab. So we've given itolizumab. That's an anti-CD6 humanized Ig1 monoclonal antibody. It binds to the domain 1 of CD6. That's actually responsible for priming, activation, and differentiation of the T cells. So that's what we have given this child. That's what about 1.6 milligrams per kilo IV infusion over a period of 6 hours. And within 24 hours, this child's hemodynamics have improved and this child's fever is gone. So the repeat 2D echo showed that the normal coronaries, and the child was later discharged with tapering dose of steroid and aspirin. As you can see the numbers here at the bottom, the CRP, the ferritin, the procalcitonin, the fibrinogen, LDH, D-dimers, IL-6 numbers have reduced, but we went by the clinical picture, and that's what this child had. So this is a brief for how we've managed giving steroids in these children. This was published in the Indian Academy of Pediatrics and the Journal of Adolescent Medicine in India. So the steroid indication mainly was with the respiratory support. Only and only if the child is needing respiratory support, be it oxygen, NIV, invasive, mechanical ventilation, and it's proven to be either MISI or COVID, those are the children who need steroids and nobody else. And even shock as well, underlying condition requiring chronic steroid treatment. The dose, our first choice was dexamethasone, 0.15 milligrams per kilo, once daily, maximum dose of 6 milligrams for 10 days. Prednisolone, 1 milligrams per kilo, once daily for 10 days. Or methylpred, we went up to 2 milligrams per kilo, and depending on the severity of the child, as I said, the pulse methylprednisolone, we had a couple of children whom we have also given 30 milligrams per kilo per day for the first 1 to 3 days, for 3 days usually, and then followed by 2 milligrams per kilo for the next, and we taper it up. So that was the first child. I'll be happy to take questions. And I know in the audience, my teachers at Sydney Children's ICU, and all of them are there. And I would love to have some questions from them, maybe at the end, or even if you could interrupt in between, I'm okay for that. So by the time you, let's go on to the second case. So this child is a 2-year-old girl, baby Khadija, third born to a third-degree consanguineous parents, apparently asymptomatic and well 9 days ago, initially presented with only loose stools and fever, admitted in another hospital in Karnataka with decreased urinary output and NSARCA for 2 days. There was difficulty in breathing, irritability, and inability to recognize parents for 1 day. This point is quite important again because in the family again, this child's paternal grandparent has actually passed away with COVID-19. That was again 4 to 6 weeks prior. So these were the features on examination. The child was sick-looking, febrile, drowsy with altered behavior, irritable, pupils were reacting, but as I said, tachycardic, pulses were felt, capillary fill time was more than 4 to 5 seconds, blood pressure was 84 on 31 millimeters of mercury. Screening 2-day echo showed a collapsible IVC with good LV function. The child had significant acidotic breathing, and blood gas showed both metabolic acidosis as well as respiratory alkalosis. And there was hepatomegaly and anuria as well. So our differential diagnosis was pretty straightforward. We said the first thing we thought in mind was, yes, the history was loose stools and vomiting and fever, so we thought it could be a gastroenteritis causing a severe dehydration and an ADN. So that was one, acute tubular necrosis or acute kidney injury. The second thing we had in mind was severe sepsis with multi-organ dysfunction because there was a complete shutdown. The third etiology in this part of the country, in the tropical, this is absolutely a season for dengue, leptospira, rickettsia, malaria, and at the same time, we need to think about the post-COVID complications of MISI were considered. So all the investigations were sent and the blood culture was sent as well. So this child had to be ventilated in view of the acidotic breathing and difficulty to maintain the airway given the sensorium. So there was impending respiratory failure. This child received intensive care management along with inotropic support, had broad spectrum IV antibiotics on board in view of the suspected sepsis. And in terms of this, in view of the severe metabolic acidosis, and as I said, this child was an oliguric AKI stage 3 and has had 9 sessions of hemodialysis almost on a day-to-day basis, and only at the end we had it on alternate days. Kidney biopsy was done by our nephrologist, and that showed to be acute tubular injury. And if you see the bloods, if you see the investigations to start with, the creatinine which was done outside was around 5.8, and here at our center was about 4.3. They were elevated liver enzymes, and there was coagulopathy as well. So in this child, again, the COVID antibodies were grossly elevated, 150. And in view, as I said, we've had everything on board. We've treated this child with antibiotics, but it's 3 days, and the child continues to have fever. With all these things on board, we've said, yes, this is MISI, and we've given 2 grams per kg IV immunoglobulins, and we started on steroids as well as aspirin. But what happened was, despite adequate treatment for both MISI and the renal failure, along with the renal replacement therapy, there was absolutely no improvement in the child's status. The child was continuing to be dialyzed, and the child continued to have high-grade fever, about 3 to 4 spikes of 102 and more. The procalcitonin initially was 100. As you can see, the other numbers are okay, and the D-dimer was a bit on the higher side, around 3,000 and 2,600. The IL-6, in fact, tended to go up when we repeated the bloods, so did the pro-BNP. This is where we were at a crossroads and we said, listen, this child, most probably it could be, we were expecting some gram-negative bug to be there because the child started off with having loose stools, went into renal dysfunction and failure. We thought about MISI, we've given that, what next? We were really at split ends and said, listen, let's think about a new onset sepsis or any other secondary infection, and we did the whole blood works again. Absolutely, the repeat septic screen and the blood culture were completely ruled out negative, but the COVID inflammatory markers, as you just noticed, they were continued to be elevated. Here again, then we've decided, yes, this could be a drug-resistant MISI was considered, and that's when we've given the second dose of IV immunoglobulins. We had to go up to 30 milligrams per kilo pulse dose of methylprednisolone. So that was a Sunday, and he said, now let me tell you a little bit about tocilizumab. Ever since last year, when there was a bit of an indiscriminate use of tocilizumab and itolizumab, this time around, the government has made it mandatory that if you've got to have the tocilizumab, you have to have the permission from the government, from the DMHO, that's the authority. So we applied for tocilizumab on Saturday while we were giving the IV immunoglobulins. We got the clearance on Sunday, but by Sunday evening, the fever settled. So with both pulse dose of methylpred as well as the second dose of IV immunoglobulin. So, and this child dramatically improved and was extubated on day 8 of admission, shifted to the ward on day 12, and discharged on day 17. That's the 6th of August. So today is the 25th of August. So that's about 2.5 weeks ago. And this child is doing extremely well, extremely well. Next slide. So this is the third child that I'm going to talk about. I would, as I said, I would love to have some sort of an interaction. Maybe I would want to learn from the expertise, the collective expertise that you all have, at the same time sharing our thoughts where we could make it better. So this little boy's name is Nihant, and he's the third born to a non-consanguineous parents. He's a previously fit and well child. He was admitted in a pediatric hospital locally with fever for 3 days and status epilepticus. So this child had seizures, was investigated for fever and started on supportive management initially with IV antibiotics. They had an MRI done there and had an antiepileptic also on board. What they've given was elebipil. Then in the referral hospital itself, they did the antibodies. The antibodies were elevated. The CRP was 188. This was a second CRP. The first one was, I think, 200 or 300 plus. The troponin was 23.5. The proBNP was massively elevated, 2,433. The D-dimers were in the 7,000s, and the ferritin was 548. So they made a decision to give the IV immunoglobulins. So they've decided to give the dose of one pulse dose of 10 milligrams per kilo of methylprednisolone as well as IV immunoglobulins 2 grams per kilo. So, but as the child's sensorium continued to deteriorate, that's when the child was referred here. So they did max what they could. But by the time we saw this child here, this child was GCS was something between 6 and 7. Quite a significant strider, unresponsive, not visualizing, very shallow breathing, heart rate was 118, blood pressure 98/60, capillary time peripheral perfusion was good, and as I said, GCS was 7, and there was a bit of facial puffiness and pediatric edema as well. This is the child. This was the stage we had to intubate the child at admission for predominant poor GCS. So we were able to secure the airway, shift him to the ICU, and the child has been stable after that. So the child didn't need very high pressures. It was more for the GCS and the airway. This child had to be intubated. So this child was on 4 antiepileptics in the intensive care. Our DDs, I would certainly expect your inputs in this management as well. Our differential diagnosis was meningoencephalitis to start off with, viral or bacterial. This is again the season for that. Sepsis with multi-organ dysfunction or a drug-resistant MISI. They've already given 1 dose of IVIG and 10 milligrams per kilo of methylpred, but that was the differential diagnosis we had. All the relevant investigations were sent. Broad-spectrum iron antibiotics were given. The child was on meropenem, including doxycycline, because we had 1 doubtful SCR on the body. So those were the bloods. The CRP was high. The urea and creatinine were 86 and 1. This child was hypoalbuminemic, and I said there was puffiness. LDH was elevated. D-dimers were grossly elevated. Fibrinogen was almost thrice the level, and IL-6 was significantly elevated as well. All the others, dengue was negative, typhoid was negative, malaria was negative, and the blood culture was sterile at the end of 48 hours. And there was no coagulum. This child continued to have altered sensorium, and seizures persisted, as I said. So we thought, let's have a lumbar puncture done. Because we might be missing something, either bacterial meningitis or one of the viruses. So we got an LP done, we sent a complete viral panel, and then we started acyclovir as well. So there are about 30 cells there, 90% lymphocytes, 10% neutrophils, sugar was 108, protein was 148, and the culture was sterile. There were 10% neutrophils, so we also had bacterial meningoencephalitis in our mind. And at 72 hours of admission, the rickettsial PCR has come back positive. But the child was already on doxycycline since admission, as we've already had a high clinical suspicion. So that's the MRI, because this child, every time we try to wean the midazolam to extubate the child, this child would continue to have seizures. So we know that this child has had an MRI done, and the opinion was that it could be a viral meningoencephalitis, but because we were getting nowhere, we've had an angiogram and a venogram done as well, a contrast MR, angiogram, and a venogram. So, and we had a long discussion with our neuroradiologist. The old MRI, he said there were multiple minor punctate hemorrhages, which were again suggestive of viral meningoencephalitis, or secondary to the status that he's had in the past 4 to 5 days. And the MR, angiogram, and the venogram, the opinion was it was an acute encephalopathy with biphasic seizures with late restriction, suggestive of post-viral meningoencephalitis without any cranial nerve involvement. We also thought that because rickettsial was possible, is there a possibility that this could be rickettsial meningoencephalitis? But there was absolutely no evidence of cranial nerve involvement with multifocal white matter lesions. We've had a bit of a debate here between the neurologist, the neuroradiologist, the actual normal the radiologist as well. It was unlikely to be a rickettsial, yes, because there was no cranial nerve involvement. But again, could it be a COVID or a MISI encephalopathy? There are not many reports across the world. There were only a few case reports about a few MISI encephalopathy children, and that was more in features or more in favor of an edem. But this was again classically not fitting into an edem as well, because there was late restriction here, and the neuroradiologist again felt that yes, it could be MISI, but we're not ruling it out, but it could be some other viral meningoencephalitis as well. So with all these thoughts in mind, there was absolutely no improvement in the fever spikes. Inflammatory markers remained elevated, and so that's when we thought yes, drug-resistant MISI was considered. That's when the child received a second dose of IV immunoglobulins and 2 milligrams per kilo of methylprednisolone. And on day 5 of admission, the child's fever spikes got better, and the child was successfully extubated on 21st August. The child is still in the ICU recovering, and actually just shifted to the wards just now. So those are the 3 cases that, or I thought the ones that we had difficulty, so that I thought might be of interest to you, and certainly I would like your inputs. And before I close, I thought I'd briefly talk about 2 things. One is follow and take home message, and then we can go to discussion. So first, what are the follow parameters? I tried looking up, there were none or hardly any, because it was all a new disease. So we tried to gather bits and pieces from all the articles that we could get, and we thought we would follow up with CBP, CRP, ESR, TROPI, CPKMB, 2D echo, and a cardiac MRI. So that was the plan. So in all the children that we managed so far in 2020, all the children, we followed them up. We wanted to do a cardiac MRI for all of them who had a bad MISI, but it was difficult to do it because it's expensive. 4 of the children did undergo cardiac MRI to rule out residual cardiac inflammatory changes. 3 of them had cardiac edema even at the end of 3 months. So this is where my concern is, because if you see the adult literature, they say that yes, it causes a lot of structural damage and structural changes in the lungs as well as the heart. So how long do we need to follow up this child was another big thing in our mind as well. But thank God, all the 45 children, they're all thriving well after 6 months of follow-up, and even children with acute COVID, they're also doing well. So these are a few thoughts that I come up with as a take-home message. I think my intensive care colleagues and my teachers at Sydney kids would agree with me. I think the first thing is early identification and recognition. There is absolutely no substitute for trying to identify shock and trying to intervene with respiratory support as soon as needed. The next thing is, apart from early identification, is trying to categorize the problem, whether it is acute or moderate or severe or messy. Because targeted intervention is very, very important. Specific and targeted intervention, effective suppression of the cytokine storm is very essential in saving these critically ill children. Luckily, we've had time, and we were able to. By the time we decided they were, in terms of management, there were times when we had a lot of difficulty. But effective suppression, trying to get it on board, whatever the immunologists that would want to, that's extremely important. Next thing is suspecting any febrile child with an unknown etiology, high index of suspicion, not only in normal children, because we've seen absolutely normal children. Usually the saying is it's only in children with comorbidities, or no, even absolutely normal, fit, healthy children. Somebody is not fitting into the picture, fever not going away, certainly think of them, especially the high risk group. But we've had a very good run with all our nephrotics and cardiac kids and all the high risk children. They've all been doing well. Next thing is appropriate and early testing. And as I said, categorization and overlap. Initially, we were trying to, when we categorized, we noticed something. I said, listen, this got features both of severe COVID as well as messy. See, we have to understand, for sake of convenience, there is a nice sort of chronology of the events which happens that is described in the sort of various articles. But what you have is, that is for theoretical purpose. Practically, what you see, yes, categorization is important, but at least 10% of the children we have seen overlap. So it's very important that we need to have an open mind and then ability to see yes, this or that, and then have a lot of multiple discussions as to which way we're going, right or wrong. So the most important things here is correlate clinical as well as laboratory findings. And as my colleagues were pointing out here, extremely important point. I think too much of emphasis has been laid on labs. Most important emphasis is your clinical correlation. Nothing to beat our clinical correlation, trying to see who needs it. Sometimes, as you've seen in the numbers, the D-dimers are very, very high. Just now I was talking to one father of a child whose D-dimers were 6,000 to 7,000, and the child was fine. I had a tough time trying to convince the parent that yes, D-dimers could be high, but as long as the clinics are fine, you don't need to treat this child. It's a challenge. It's a challenge because now all the parents are aware. They know what D-dimers are. They know what other numbers are, and they're just freaking out. And you have to be even more careful, because especially here, we have to understand that we have to make a conscious decision. If the clinical features are normal and the D-dimers are high or other inflammatory markers are high, we have to consciously tell them, yes, you can back off with the treatment. But I have to have things in my mind. What if things go wrong? Next couple of days, I get to be blamed. So it's a catch-22 situation. It's a very difficult situation. What's important here is multiple discussions that you need to have at your level. That's important. So, but I would certainly give more value to my clinical findings rather than my laboratory findings. For example, these two children whom I'm treating right now, yes, one child's clinical condition is good, so I deferred them from getting the IV immunoglobulins, whereas the other child, the D-dimers are not that much elevated, but the clinical findings, the fever is high, it's really raging, and all the other symptoms are there. Yes, that is when I would give it. So there's a clear-cut distinction in the management. So I think we need to stick to our basics rather than going for all the flamboyant things. That's what we've learned in the last 16 months. Next thing, I think we should learn to question a lot as well. For example, if you see the WHO classification of MISI, and the slide was played earlier, it says clearly that MISI has to be a diagnosis of exclusion. That means every single pathology has to be ruled out before you even diagnose MISI. That I would categorically stick my neck out and say that's wrong. That's wrong. Because as you've seen, all the children that we have seen, we had children with dengue, we had children with leptospira, we had children with gram-negative infections, lots and lots of children. We went the right way. That means we treated the underlying condition first, waited for 1 or 2 days, and then if the child is still not getting better with the clinical features, that means the hemodynamics as well as the fever, and on top of that, apart from this, the numbers. If both these things are matching, then we have absolutely no two ways of going about it. Just we went for the treatment of MISI, no doubt. So this certainly I would like to beg to differ with the definition of MISI with the WHO. I think with time, they would be forced to change their diagnosis, because it's not only me that I'm observing all across the country. See, because our country is a tropical country and we have lots and lots of infectious diseases compared to those in the Australia as well. But at the same time, we can't forget the basics. I'd rather displease the WHO mighty well, but not displease my child and my parent. Absolutely, they're more important to me. So yes, we have not followed the WHO guideline in these matters. And I think there's a lot of research that needs to be done. And down the line, we will be able to gather more evidence. And I think common sense should prevail and the definition should change a little bit. Next, most importantly, not biologicals and mostly basics. There's no two ways about it. Because what's important is, again, the treatment should not be worse than the actual disease. We made a couple of mistakes, mind you. Initially, there was a flurry of these things about tocilizumab, anakinra, and itolizumab, and remdesivir, and all sorts of drugs. Now the latest stage is monoclonal antibodies. 1 day of fever, children, they're saying, yes, doc, can we have monoclonal antibodies? Everything is fine, but what we have to understand is the treatment should not be worse than the actual disease. So first, last year, we did give some children tocilizumab. In hindsight, that was wrong. I'm happy to accept that. But I think we need to stick to our basics. And as I said, follow up. See, we don't know what's in store. We absolutely don't know what's in store. We have managed these children this way. It's been 15 months. They've been doing well. What's the long-term follow-up? That is something which is extremely important. And I think we need to continue to do that. And that's what we've been doing. Thank you so much. And as I said, I would love to listen to all your comments. And feel free, because we are also going through a learning phase. And it would be lovely to hear from you.
Thank you, Dr. Satish. That was an excellent webinar. And thank you, Dr. Sujit and Dr. Sridevi, for presenting the different parts. Quite an educational webinar. And I'm sure all the attendees who have attended this webinar live and those who will be watching the recording later on will find it very informative and useful. Now, I think we have got a couple of questions in the Q&A box. And I will hand it over back to Dr. Satish to go over those questions and answer.
Yes, that's Dr. David. What's the proportion of your 2021 cases are the Delta variant? Yes, if you first let me say that now as a country, we are close to 65% seropositive. So 2/3 of our country has already had the disease or the vaccination. And if you see this Delta variant, the earlier one, which was actually first seen in rural Karnataka, and that's what has spread widely. That's the predominant cases that we see right now. Yes, are we doing viral testing for each of the tests? No, the size and magnitude in this country, absolutely, we can't test each of these viral typing. We cannot do. There are 10 virology labs in the country, and the government does take the samples and they measure it. And all the 10 virology labs across the country, they have come to a conclusion that 80%, close to more than 80% of the children are and the adults are in the Delta variant. I hope that answers your question, Dr. David.
The question is regarding access for the general population to your healthcare service. Is this a private hospital? That's the question.
Yes, Yaro, yes. Access for general, yes, ours is a private facility. Ours is a private facility, and a little bit more information in Hyderabad, which is the size. Actually, I should have said that earlier. That's my mistake. My apologies. If you see Australia, the population is 25 million. And Hyderabad is one city in India, and the population of the city where I stay is half of Australia. That's about 12.5 to 13 million. And the whole of this was right now, we've just completed the second wave, and they say we might have the third wave. So during the first wave and the second wave in Hyderabad, in the state of Telangana, we had 3 centers who were taking care of children with COVID. The first is the government setup, which has seen lots and lots of numbers. That's from the Gandhi Medical College. And the other 2 private centers, one of the private centers is us. So all the numbers, so you can multiply it by, let's say, 2, because the government hospital had a lot more. So you could multiply my numbers by 10. So that is the kind of numbers that you've had. That's number one. Second, regarding access for the general population, as I said, ours is a private facility. But if we have seen about 30% of the cases, the private setup, 70% of the cases or the children were managed in the government hospital. I hope that answers your question.
Yes, thank you, Dr. Satish. I would request all the attendees to please put in the questions in the Q&A button. Please do not use the chat option. This is just to streamline all the questions on one platform. Dr. Satish, you might be able to see a Q&A button.
Yes, I can see it. Yes,
and that would,
between myself and Sujit will try to answer this. Yes. So how long was the steroid duration you observed in any cases of adrenal insufficiency? We haven't had any child with adrenal insufficiency underlying, but we had a catecholamine resistant shock, and the usual duration was 10 days. The mean duration was 10 days. Dr. Sujit has already presented that. But some children we had to give for about 15 days and very rarely more than that. The next question, did the children who died all have comorbidities, and what were they? That was the surprising point that I was trying to tell you. No, the children who died, the only child who died with a comorbidity was a child who's had a kidney transplant, and this child also had a diabetes secondary to transplant rejection. So this is a child who died. Yes, that was one of the deaths in 2020, but we've had 3 deaths last year and 1 death this year. The remaining 3 children, they were all otherwise unsuspecting, healthy children. How long was the steroid duration? Have you observed? Yes, I've answered that. Do we know what makes the Delta variant so susceptible for children? I don't think it's just the Delta variant and being susceptible for children. See, if you see 60% or 2/3 of the population is already seropositive, and many of them are vaccinated. So if you see the numbers, roughly our country, 1/3 of the population is children below 20-25 years, or adults or adolescents. Now, so that is the percentage. And until now, the vaccinations have been happening only to the adult population. So yes, a big number, a big chunk of adults have been vaccinated. So they either had the disease or the vaccine. Now coming to children, none of the 18-year-olds and less than 18-year-olds have had their vaccine. So that is predominantly a susceptible population. And on top of that, they have not been vaccinated. So that is the reason. And mind you, I think we should dispel this fear. They are, in fact, if anything, now the Delta variant, the success rate that we're having is 100%. In fact, only 1 child died. So that's it. In Missy, it's 100%. So absolutely, Delta variant being more susceptible to children, sick children, that's not the case. In fact, if you do all the ABC right, I think the success rate is fabulous and 100%. When do we find IgM and how long does it stay before IG? Okay, so that's Primla Kar. So question is, when do we find IgM and how long does it stay before IG appears? See, we have day 0 of the illness. We have day 0 of the illness where the symptoms are not evident. It takes 5 days or 7 days for the symptoms to come. So that is day 0 of the onset of symptoms. So anytime from the onset of symptoms, the IgM can be there. It can be there for 2 weeks. And IgG starts roughly from 10 days to 14 days onwards since the onset of infection, and it can last God knows. Why I'm saying that is because some antibodies have disappeared within 3 months altogether. Some of them have lasted 6 months. So we don't know this weird disease, how long the IgG lasts, or is there a humoral immunity and a cellular immunity? Is there a sleeper cells which are involved, which with the next infection they kick in? So we absolutely have no clue. But I think for all practical purposes, IgM and IgG, that's the timelines. But one more important thing here is, yes, we are diagnosing children with Missy. Last year it was very easy with IgG, very, very easy. But here, the difficult thing here, which I would certainly need comments from the intensive care colleagues in Sydney as well, is, as I said, 50-60% of the population is positive, seroprevalent. So they're all IgG positive. They've had the disease or adults had the vaccine. So now, what is the challenge? Because we're having these infectious diseases. At the same time, we also have the children who are positive for IgG. They're seropositive. That doesn't mean to say that they're infected. They could be just silent bystanders. The IgG positive is just a silent bystander, and it's not contributing to the disease at all. In fact, it's helping out the child and making the child not get the disease again. Okay, so that's where we are, and so it's very, very important with the clinical aspect. If the child is sick despite the primary infection, that's when we have to go in, do the inflammatory markers, and if they're elevated, then only we need to treat for Missy. Next slide, please. Third case: agree acute encephalopathy with biphasic seizures and late restricted diffusion. Was CSF examined for viral PCR? Beautiful question. Yes, we tried, but at the moment in the country, we failed quite miserably because last year we had a neonate with a similar problem, and we sent the CSF for COVID PCR. They said they could not standardize it because this PCR kit or tool which is available right now is only meant for the nasopharyngeal swab and the throat swab. Unfortunately, it doesn't categorize or standardize the system for CSF. So we did try. but that was SARS-CoV-2 positive, RT-PCR positive in the throat swab, had meningitis. That was another child in the newborn, but turned out to be negative from a PCR from the CSF. So yes, we did try, but it didn't work out. And we did do the literature as well. There were a couple of cases from Germany, and there was a couple of cases from Japan as well, where they sent the CSF off. But as I said, every test, the PCR has to be standardized for that particular thing. PCR for throat swabs or PCR for blood and things like that. Yes, next question. Could I also please ask you to comment on your follow-up schedule for echo after the MISI? Your first follow-up is at 3 months, if I understood correctly. Would you consider the KD-like schedule 2 weeks, 4 weeks, and subsequently? As absolutely, that's fantastic, Dr. David. That is something that we have done. Again, sorry, because we didn't know what the precedence was, and yes, initially we planned it for 3 months. But children who had the KD, we had them come more often, and those were the children out of the 4. We've had the cardiac MRI done, and those children we had the cardiac MRI. Those are the children we continue to have the swelling. But as I said, even the interventional radiologists, even they didn't have a clue, because they didn't have a precedent of how a MISI affects the heart or how a KD affects the heart. So that was the challenge we had, and that was different. That's a fantastic suggestion, and we are actually, for all the KD-like illnesses, Kawasaki disease-like illnesses, we're trying to have less of them as well. So that's it. And hi, Dr. Garrett. Hi, Dr. John. Yes. Does the vaccination status? I thought tocilizumab should be given once oxygen therapy is needed. Yes, Dr. John. That was the thought process. As soon as the oxygen therapy was needed. But yes, if there is MISI, basically it is immune dysregulation. If you see the pathology, one is immune dysregulation, and the second is your prothrombotic state. So that is when, yes, tocilizumab, initially when they said, yes, once the oxygen therapy is needed. But last year, there was an absolute overkill. And then the immunologists were shouting to the rooftop saying, I think we are using way too much than what is actually needed. There are a lot more immunosuppressive side effects of tocilizumab than, if you see the benefit and the risk. So we went away from that. Even this child who we didn't get tocilizumab, but, got better with the second dose of IV immunoglobulins. That was the thought process we had last year, Dr. John. But this year, yes, we have tocilizumab. Now our idea or the hierarchy is, number 1, treat the underlying disorder, IVIG 2 grams per kilo. Methylprednisolone 2, and if it doesn't work, 2 milligrams per kilo. If it doesn't, you could go to the pulse dose, that is anywhere between 10 to 30 milligrams per kilo, depending on the severity of the child. And if the fever is high, inflammatory markers are high, hemodynamics are still unstable, then we would consider a second course of IV immunoglobulins, and then only we can get our hands onto tocilizumab or itolizumab. That's what we are following. I could be wrong. I could be absolutely wrong, but I'm happy to be corrected. But that's what we are following right now, Dr. John. Thanks for the question. Thanks. Then, Azana, the cases with MISI that you described displayed symptoms only after more than 3 weeks after the death of the index case. Did this change the duration of quarantine recommended? Absolutely fantastic question. So, more than 3 weeks of the death of an index case, yes. But did this change the duration of quarantine? Yes, it did change. Then again, initially, if you see, the quarantine was very strictly followed, at least in our part of the world. Initially, it was for 14 days. And then if you see the CDC recommendation, the quarantine is only for 10 to 12 days. And then they kept changing, and they said, listen, even if you shed the virus, it's only a viral particle, it's dead viral particle, it's absolutely fine. In fact, they went on to say that you don't need to even do a repeat RT-PCR at the end of 10 to 12 days. I'm not 100% sure. Is it because of the lack of infrastructure / RT-PCR kits, or is it truly that is what is actually the recommendation? But there's a lot of chops and changes to that. But that's a very good question. Thank you for the informative talks. Have you noticed any difference in presentation between children with and without comorbidities, and do presentation with different variants? So 2 different questions there, Dr. Tina. First thing is difference between children with and without comorbidities. In fact, if I may say so, I would like to say something different. It's in fact the children who've been absolutely normal. They are the ones who've taken a hit. I understand the literature all says comorbidities, but all our leukemics were good. All our nephrotic syndromes did better. And we've had a lot of leukemics who had this, but all of them have done well. Now, there's one death, as I said, that's the child with the kidney transplant, which was done. The other question is, do different presentations with different variants differ? This is a question that I'd like to answer. Ask this question, because unless we have a complete or a perfect, epidemiology done as to this is what it is, you have to understand, Dr. Tina, that the condition in Sydney, Australia, Canberra, Melbourne is very different. Here, we have a population of 1.3 billion. And as I said, the state which I come from, the city that I live in is half the size of Australia. It's a big, massive country. And ideally speaking, yes, if all these samples would have been tested, and again, the difficult part is, how do I know that it's a Delta variant? MISI, secondary to the MISI, because this child, the basic question is, this child had the disease 4 to 6 weeks earlier, right? Now I'm getting MISI, that is 2 to 6 weeks later on. There is no virus in the body. So it's only based on the clinical features, based on the hemodynamic instability, and most importantly, equally important is your blood investigations or your inflammatory markers. It is these which we are able to sort of identify who the sick babies are or not. But we do not know whether they come from a Delta variant or not. Yes, I agree with you. If it's an acute COVID, yes, we would know. But that again, in a country like this, would be difficult. But that would be the ideal case scenario.
Dr. Satish, there was also a question from Dr. Blessy Charles, who was asking, does the vaccination status affect the development of MISI?
MISI, very, very beautiful question again. I absolutely don't have an answer, because all the none of the kids are vaccinated right now. All the vaccinated people are only above 18. So our population, we are seeing children. Obviously, none of them are vaccinated. Number 1, and number 2. All these children, they're not vaccinated, but as I said, 60% of them, close to 2/3 of them are seropositive. So yes, it is, I think, more than the vaccination, it is the disease that they would have had, or they would have got transmitted from their parents or their relatives. So vaccination status, it would have been nice if you had the information, but yes, unfortunately, we have to wait for 1 year to answer that question, because none of our kids are vaccinated. Next question, Nicola, did you notice a higher risk of prevalence in kids who had close contacts with fatal outcomes, as seen to the case with the patients you discussed? Absolutely, Dr. Nicola, you're absolutely right. Yes, viral load is extremely, extremely important. That is why the CDC recommends that if you're now, especially if you see the Delta variant, if there is one index case, unlike the previous variants, there is a 100% chance that every child or every adult in the family or everybody would be infected. So that means the incidence is extremely, extremely high. The prevalence is certainly high. So obviously, in the scenario, we've had a father who's died, 2 grandparents who died, and I've said another grandparent. So at least in our 16 months of experience, we've had about 4 children who had it, obviously from their close kith and kin who died, and all of them, they were sick. So that's the answer to your question. The viral load does matter a lot, but I know anything else, there's a lot of questions to be answered. I'm sorry, I can't answer more than that because I don't have more information. Question from Dr. Su. So did any of the children you have managed develop blood clots, and are you using Clexane as thrombopropyl as well as aspirin? Fantastic question, Dr. Su and Dr. Kerry. The first thing is, yes, there is one child. It's a newborn. In fact, it's a MISI. We are seeing this MISI even in the newborn population. And yes, we have seen it in one child. And we do use aspirin. And we are a bit reluctant to use subcutaneous enoxaparin or Clexane. Why? Because the symptoms don't match the D-dimers. So that's a big challenge for us. And there have been some catastrophic events where people have earlier, last year, that was 2020, we tended to use a lot more subcutaneous Clexane than we are using now. I absolutely, I would love to have more information, more statistics, so that we will be guided, because many times we are having, prothrombotic states where the D-dimers are high, and we are unable to make a decision which way to go. So that's a very, very difficult question. Sorry, I couldn't answer your complete question. So did the patient in case 2 have COVID Delta strain? Yes. See, again, it's not about, I think there is a misconception here. The case 2 that we have seen is a MISI child, It's not a COVID child. That means this child had COVID infection in the past, presumably asymptomatic 2 to 4 weeks earlier on. So we had absolutely no clue, because that was asymptomatic at that time, 0. And now the child developed MISI. So there is no way you can find out the sort of the symptoms of this child, whether that was because of the Delta variant or Lambda variant or some other variant. What were the most common adverse effects of therapies administered that you have seen? The biggest worrying thing, yes, we've had to use children's steroids. Steroid-induced psychosis was there. Hyperglycemia was there. That is with the steroids. And I've had some colleagues explain about very, very adverse events with Clexane and enoxaparin being used and not being monitored properly, where they actually had torrential bleeding. So that was one such thing. Next, what were the most common adverse effects of therapies? Yes. Otherwise, pretty much IV immunoglobulins, straightforward. They can have rash in the first half an hour, but other than that, nothing. Steroids we've been using for long, they're okay, but as I said, the side effects that I've mentioned, tocilizumab, itolizumab, and acute COVID, we did use remdesivir. Thank God, none of them till now we've had a problem. But as I said, we are following them up. We continue to follow them up. Next question: have you noticed that in 2021, as cough and cold more common symptoms, the COVID positive children are presenting more with lung involvement requiring ventilation as compared to 20? In adults, lung involvement is commonest. Absolutely, doctor. I do understand that the way they presented in 20 was very scary. Children were more sick. Children were more hemodynamically unstable. But now, I'm not trying to be the devil's advocate, but with this Delta variant, maybe we are more clever, and maybe we are more equipped. Maybe we have more knowledge. We're able to treat them better. So I don't think we need to worry too much about this. And as I said, with even the Delta variant, I think, as I said, MISI, we've never had one death, and all we've had in the COVID group, we had only one child who died. That again was referred too late, almost day 9, day 10 into the illness, and the child also had a super added sepsis as well, and then the child succumbed.
I think that was pretty much it. I would also invite Dr. Sridevi and Dr. Sujit to add any inputs from them regarding any of the questions that were asked by the audience.
Sujit, Sridevi, you want to add something?
Yeah. Mostly in MISI cases, what we are regularly following up is we are calling them after 14 days. First follow-up will be in the first week, next followed by after 14 days, and next will be at 6 weeks, later on at 3 months and 6 months. This is the schedule we are following up for every children. Even with KD in shock or without shock, we are following the schedule with the follow-up of investigations, blood investigations, and clinically we are seeing the cases. And regarding the adverse effects, even we have used the steroid for long duration, like 14 days, and we are tapering over the 1 week. Total duration we are giving for 2 to 3 weeks. We haven't seen any secondary infection. That is a good thing. And only for one patient, we have used a high dose of steroid. We have managed the hypertension. We have got the hypertension in one child, which we have noticed, but on follow-up, child is doing well.
So before one more point, Dr. Rebecca has asked one question. Dr. Satish, you mentioned MISI in the newborn. Is this following an intrauterine infection? Yes, exactly. In fact, next week, in 2 weeks' time, again, we have another webinar with our NICU team. And yes, it's absolutely true. It is from an intrauterine infection. When I say MISI in the newborn, so this child acquired the MISI in the intrauterine period. And the mother had COVID positive in the 7th or 8th month. Mother had antibodies. And we tested the baby. Baby was positive for antibodies, and then we tested the mother. We went back. The mother was also positive for antibodies. We would discuss that in 2 weeks from now. Next question is Ravi. Do you have a preference for the type of vaccine that adolescent kids should get, or kids that age group after recovering from their COVID infection? Very, very good question. The current recommendation is once they've had the COVID infection, the consensus is there's still a lot of discussion happening, but roughly the antibodies might last for 3 to 4 months. So the usual recommendation is they have to at least wait for 4 to 6 months to get the vaccine done. Because there is a chance that they could still get it again. Regarding what kind of vaccine, in India we have all the other vaccines, but predominantly homegrown vaccines. One is the AstraZeneca vaccine, and the other is the Covaxin. AstraZeneca vaccine is from the spike protein and the RMB receptor binding panel. That's where the antibodies or the spike protein antibodies to that one. But what is developed in India, it's a complete virus. It's a live inactivated virus. So the antibodies are different to that. So again, people are talking a lot about trying to mix up the vaccines, but at the moment we do not have an exact answer to that. But you see the percentages. I think it's around 70% to 75% efficacy, whereas Pfizer and Moderna is close to 90-95%. But there's a lot of, despite having the vaccine, in fact, the Delta variant, what they say is there are 2 concepts with the Delta variant. It's called vaccine escape and an immune escape. So what is vaccine escape? What is immune escape? Vaccine escape is, let us say I take the vaccine, Pfizer vaccine, but despite me taking the Pfizer or the Moderna vaccine, 50% of the times, my immune system might not develop the entry of a new COVID into me, the Delta. So I could have the disease because my immune system is not having a memory of that. So that is vaccine escape. And as I said, the other one, even despite me taking the vaccine, there's a 50% chance that I can still develop the thing. So that certainly is much more with the Delta variant than the other variants in the past. I hope I have answered here. I have a very, very interesting question here. Actually, this is the current rage now in India. Are you seeing too many opportunistic infections in COVID positive patients? Number one, where COVID lowering the immunity and then producing gram-negative sepsis, meningitis, or disseminated tuberculosis, etc. That's the big dilemma right now. So it's like, the chicken first or the egg first. So that's exactly the challenge what we're having right now. We do not know whether it's the COVID which is sort of lowering the immune system, battering the immune system, and then the child is susceptible to other infections, or the other infections already existing in the community and their immune system is down, and then the COVID has easy access to these children. Absolutely, there's no easy answer. As I said, we are literally having to pull our hair just only for this, because we don't know, especially with the dual pathologies that we are seeing now, which we didn't see, mind you. It was only in 10% of 10 or 12%, I think. Sridevi has presented the data. Was it Sridevi? 13%, right? 13% of 2020 we had dual infections. 13%. Whereas here in 2021 we had 31%. 31%. Almost a third of the children, they already had the disease, like what I mentioned, rickets disease, or one child had 2 different gram-negative bugs growing on the blood culture. Whether those children, they're already immunosuppressed and then this is entering, but they are there simultaneously. And unfortunately, what is important here is we do not know, or there are no clear-cut guidelines and markers to absolutely ascertain which marker to be used for which disorder or which disease. Is it for the primary pathology or the MIS-C pathology? Absolutely none. Initially they said, oh wow, IL-6 is fantastic and CPKMB is very good, and now they talk about something else. So there is absolutely not a lot of literature. There's a lot of discrepancy. So I would stick still to my clinical features, clinical management, and then with the help of inflammatory markers. So that's a very, very tough question. And I think that's the challenge for everybody across the world, especially intensive care doctors, who you have 2 different scenarios: what to treat first, what not to treat. Is this the cause? Do I treat this first, or do I wait with the next one?
Thank you, Dr. Satish. Yeah. So on a final note, I was going to ask Dr. Sridevi or Dr. Sujit if they had anything else to add. So I'm assuming there's nothing else.
Yeah.
Okay. Well, good. Okay. Thank you. So I'll just quickly wrap up this session now, and this starts with another round of thanks to all of you, especially Dr. Satish, for the whole presentation and going in such breadth and depth of the topic, and also excellent inputs from Dr. Sujit and Dr. Sridevi. A quick note on our next webinar, which will be hosted on the 1st of September and will be delivered by Olivia Reynolds, who will be talking about physical activity in the recovery from COVID-19. So if you're interested in this topic, please register using our website. Now, we acknowledge that this talk could have been distressing for some people, especially with some of the images that were shown. And therefore, if you require any assistance or support, please contact the support services which are available in your local area. We have listed a couple of them from Australia and India over here. And a final note on the ANU COVID-19 peer support program. You can find out more about this program using this particular website, including registering for our upcoming webinars. And if you're a medical or healthcare professional, you can also register to volunteer or seek support using the same link. And we are available to be contacted on international.health@anu.edu.au. And look out for another webinar, which will also be delivered by Dr. Satish on the 8th of September on neonatal COVID.